This capture looks at auditory disorders. We'll begin by taking a brief look at the anatomy of the ear, keeping in mind the external ear of the auricle and the external auditory canal, getting into the middle ear where the tympanic membrane is, the malleus and the incus and the stapes, and then into the internal ear where you have the cochlea. And this is just a better view of the anatomy of the inner ear. So when we talk about auditory assessment and ear assessment, we're going to begin by inspecting the external ear, looking at the outside for earwax, any type of hair growing in the ears, things like that, and then moving on to the otoscopic examination. And you can see the pictures on the screen in the center. The top one, that pearly gray color, that's what a tympanic membrane should look like. The one below that shows a very irritated, infected, inflamed tympanic membrane. Other things of assessment, you can evaluate gross auditory acuity, so just speaking to the patient in a normal tone and volume of voice, and are they able to hear you? You can then go into the whisper test where you're off to the side and you whisper, 1, 2, 3, or, whatever, and can they hear you? You can do the same thing with the watch tick test where you put your watch up to them. Can they hear the ticking of the watch for one of the old-fashioned, analog watches? And we can also use the tuning fork to evaluate the Weber test and the Rene test. Okay, and those are all about sensorineural and conductive hearing loss. For diagnostic testing, audiometry is the most common thing that you'll see. That is the measurement of hearing acuity, and it evaluates frequency, the highness or the lowness of tones, and those are expressed in hertz. Intensity of sounds is expressed in decibels, and the threshold is the lowest level of intensity at which pure tones in speech are heard by the patient. They can look at a tympanogram, looking at the tympanic membrane. They can look at an ENG, an auditory brainstem response. Those are more related to damage to the acoustic nerve and looking at damage to the actual brain tissue. So you might hear of caloric stimulation. This is a test that uses differences in temperature to diagnose damage to that acoustic nerve. So that's the nerve that's involved in hearing and balance, and it also the test checks for damage to the brain stem. So what they do is they put a small amount of cold water or air is gently delivered into one of the ears. As they do that, the patient's eyes should show involuntary movement called nystagmus, and it should turn away from the ear where the cold water was instilled and then go slowly back. If you use water, you want to drain that out of the ear canal. Again, they'll do that with warm water. This time the eyes should turn towards that ear and then slowly back, and then they can test the other ear the same way. That is not typically something you're going to see done very often. Now we have some of the newer testing that we can do when we're looking at brain function and cranial nerve function. So looking at hearing loss, the most important thing to keep in mind is that it is preventable. We know that exposure to loud noises, we know that infections, particularly recurrent, repeated infections, and certain medications can cause hearing loss. When we think about those medications, antibiotics, the ones that come to mind, gentamicin, amikacin, and metronidazole flagyl, are all associated with hearing loss. Diuretics, particularly furosemide or Lasix, is associated with that. NSAIDs, particularly aspirin, is associated with hearing loss as well, and are some chemotherapy agents. Early symptoms of hearing loss include tinnitus, which is the perception of sound often like a ringing in the ears. These patients also tend to experience a progressive inability to hear in a group, so it gets more difficult to distinguish conversation when you have a group of people and multiple things are talking. And you'll also notice that they'll tend to turn up the volume on the TV. The biggest thing to keep in mind is that, very similar to glaucoma, hearing loss, the impairment tends to be very gradual. It happens, slow and insidious, and the patient tends to compensate. They might turn their head in the direction of a conversation to hear better. They might sit closer to the TV. They might increase the volume on the TV. So family often tend to notice the hearing loss first before the actual patient. As the hearing loss continues, you may note some deterioration of speech. You might see that they don't necessarily respond as well when you're interacting with them, and partially that might be because they cannot hear and they're not processing what you're saying. You may see some social isolation or withdrawal because they don't like to be in situations where they can't hear, or people will kind of figure that out. So the two types of hearing loss are conductive hearing loss and sensorineural. And it's very important that they distinguish what type the patient is experiencing. They could also experience mixed as well. But you kind of want to know the type, because that's going to help guide some of the treatment and what we're going to do. So conductive hearing loss involves the external or middle ear. So common causes of this are otitis media, which is your ear infection, your middle ear infection, and otosclerosis. So these patients actually report better hearing when they're in a noisy environment. So things to kind of focus on is the client's speech, actually looking at the otoscope exam findings. With sensorineural hearing loss, the issue is with the cochlea or damage to the vestibulocochlear nerve. Okay, so it's inner ear. Causes of this: Meniere's disease, which we're going to talk about in a little bit, ototoxicity, it could be a congenital problem, diabetes long term, your noise trauma over time causes sensorineural hearing loss. So this is the most common that you're going to see, and these people will report poor hearing in a noisy environment. So some things to keep in mind, regardless of what type we're talking about, how we can improve communication with our hearing impaired clients. You want to use a low tone, but a normal voice volume, okay? Sometimes as we get excited, we tend to get a little bit higher pitched, and they have more difficulty hearing us. You also want to speak slowly and distinctly. You want to enunciate your words, but you also don't want to speak down to them. Okay, you just want to be very clear in what you're saying. Less is more. If you can say what you're saying in fewer words, it's going to be better for these types of patients. You want to reduce background noise and distractions. So close that hospital room door. Turn the TV down. Make sure you're facing the person that you're going to be speaking to, and make sure you have his or her attention. If they have a good ear, a lot of times it affects both ears, but if they have a good ear, make it a point to speak into the ear that's less impaired. Use your gestures and use your facial expressions. Those nonverbals really help convey the message that you're trying to send. And if necessary, write out the information, okay? Or if they are deaf and they use ASL, get a sign language translator. So ways that they can help manage the hearing loss: lip reading. It's actually very difficult to do, especially if the person that you're trying to read their lips is not enunciating what they're saying. Sign language, of course. And then we have hearing aids. So some things to consider with them: loud environment considerations. Even if they have a hearing aid, I still want to take those steps that I was mentioning earlier about reducing background noise as much as possible. You also want to be familiar with the settings of the hearing aids. A lot of times they'll have different volumes. Also making sure the patient and you know how to clean them, know how to replace the batteries, where to get replacement batteries as needed. Something to really keep in mind is hearing aids, good ones, are very, very expensive. And the newer ones that we have today are very, very tiny, and it is very easy for them to get lost. So you really want to make sure that we're taking care of those patient belongings, that we're documenting what they have on admission. A lot of times I'll give them a denture case or whatever, and we'll specifically mark it with a label with their name and hearing aids, just to make sure we're storing things appropriately and getting it back to them. Cochlear implants, this would be for people with the inner ear problems. These are for patients with profound deafness. There's two pieces. There's a surgical device that's inside, and then there's the external processor that they tend to wear behind the ear. The ideal candidate for a cochlear is somebody that has sensorineural hearing loss, but they experience that hearing loss after they learn to speak and learn language. Okay, if they are born deaf, they can do a cochlear implant. You're just not going to see as good of an outcome long term with their abilities and their ability to function in everyday life. Looking at external ear conditions, something that is very, very common, particularly in the older adult population, is cerumen impaction, which is basically just packed earwax that's in there. So you want to keep in mind you're not taking Q-tips in there and digging in there. What they typically do is they'll do irrigation with suction or maybe even some instrumentation. That instrumentation would be done by the provider, not us. There are ear drops, such as Debrox, that we can instill in the ear that will help soften and moisten and loosen the earwax, that it can come out more easily by irrigation and suction. Hydrogen peroxide is helpful with that too, but you're really trying to remove that earwax. A lot of times that impacted earwax could be the cause of their hearing problem. And once that part is resolved, they might see a significant improvement in their hearing. Same thing with foreign bodies. Removal can be irrigation, suction, instrumentation. Objects that can swell should not be irrigated. In severe cases, they may need to go to the ER. In severe cases, they might need to go to the OR to get these things extracted. And I'm always reminded by the one case that I saw in Untold Stories of the ER where this person had a cockroach in their ear. And it just kind of makes me twitch there, but that they, had to get that out of the ear. That was kind of creepy. Infections in the ear, again, externally, otitis externa. This is infection of the external ear and the external ear canal. Very much associated with swimming. You may hear this called swimmer's ear. And basically is caused by bacteria, or sometimes it's a fungal infection. But it's going to be pain and tender. There might be some discharge and swelling in that external ear canal. Typically it's treated with antibiotic ear drops. They might need to use a cotton wick. Sometimes it gets so inflamed that literally that ear canal is swollen shut. So what they'll do is actually the provider will insert a wick down in there, which is just a tiny little piece of like string. And when you put the ear drops in, it'll get the wick wet, and the wetness will actually wick down the wick into the inner part of the ear. And it will take some time to get that infection cleared up. Pain management will typically use analgesics, usually acetaminophen, and also warm compresses. Otitis media is infection in the middle ear, and this is very common in children due to the angle of the eustachian tube. Also, if they have large tonsils or large adenoids, that can put them at risk, as well as frequent air pressure changes. We tend to see this a lot in patients that have frequent air travel. Typically, if their symptoms persist beyond 7 to 10 days, that's when we'll start oral antibiotics. We really moved away from starting treatment right away with antibiotics because of the antibiotic resistance. So we've moved away from that. Some parents need to be educated about that because, yes, that means their kid is going to be miserable for a couple days. But the reality is, if this otitis media is caused by a viral infection, that antibiotic is not going to help them anyway and is actually more harmful to that baby's body with messing up the normal flora and priming something for resistance. Okay. For recurrent infections, they might do myringotomy, which is essentially the tubes in the ears, which allow the drainage to happen so they're not getting the recurrent infections. Mastoiditis. This happens when you have untreated chronic otitis media, and it actually perforates the tympanic membrane and forms an abscess. And it's right next to the brain. It's in the brain, and it's right by the facial nerve and that. So this can be very, very serious. It's typically treated with IV antibiotics, and they may have to do an incision and drainage of that abscess. So post-operatively, they're going to position them on their side. They're going to have the surgery side up. There's typically going to be packing in where they did the incision, so that will need to be changed and dressed daily. Otosclerosis is another middle ear condition. It is a genetic disorder, but basically what happens is you have the three bones in the inner ear, and the stapes, which is movable, this is what moves and causes transmission of the vibrations and the sound. And what happens with otosclerosis is the stapes becomes immobile. And as the sound comes in, you're not getting the movement of that bone, and hence you have the hearing loss. So they're going to monitor these patients with hearing acuity. But eventually this is going to require surgical treatment, stapedectomy. Initially after surgery, because you're going to have swelling and you're going to have fluid accumulation, their hearing is actually going to get a little bit worse after surgery before it gets better. There's also the risk for facial nerve damage with this surgery, so that's something to consider. Post-operatively, you want to limit sudden movement because they're going to experience some dizziness, nausea, and vomiting. It's very common for us to treat them with something like meclizine to help deal with the vertigo. Also antiemetics and antihistamines to kind of keep everything chill. Post-operatively, we're going to be focusing on pain relief. We'll use analgesics. It is not uncommon for them to have an occasional sharp shooting pain as the eustachian tube starts opening and allows air into the middle ear. But if they're having constant throbbing pain, and especially with fever, that can indicate infection, and we want to get on that right away. We're concerned about injury post-operatively simply because of the vertigo. So that can be a safety issue if they stand up and get dizzy. We don't want them to fall. So use of antiemetics and anti-vertigo meds such as meclizine are appropriate for this patient. We also want them to avoid any type of activity that's going to increase pressure in their ears. So we don't want them blowing their nose, which is why we'll have them on antihistamines and things like that to try to minimize all that. We don't want them straining. We don't want them bending. If they're bending at the waist and their head is going down, that is going to increase pressure in the ears and in the eyes. We don't want heavy lifting, heavy exertion, coughing, sneezing with the mouth closed. So again, those antihistamines are very, very important. Certainly no air travel. They cannot be going up elevations. They really need to not be changing elevations a whole lot. We do want to avoid rapid head movement, and they need to avoid getting any type of water in their ear, usually at least for about a week or two post-operatively. In the inner ear, that affects more than 30 million in the U.S. We worry about falls from these disorders. Falls cause hip fractures. Older adults that get a hip fracture It's going to make it very, very difficult for them to really continue living their life, their mobility, their ADLs. A lot of times, unfortunately, a hip fracture is the beginning of the end, and that's when that downward spiral starts. It's important to know some terminology. Dizziness is altered sense of orientation in space. Vertigo is the illusion that the room is spinning, the room's in motion. I have a whirling sensation. And nystagmus, which we had talked about before, is the involuntary rhythmic movement of the eyes. It's kind of like that twitching back and forth. We look for it when we're doing that cardinal fields of gaze, typically associated with vestibular dysfunction. And finally, we're going to talk a little bit about Meniere's disease. This is probably one of the worst disorders someone can have because it is just so debilitating. But they have recurrent episodes of severe vertigo, severe tinnitus, and it does fluctuate hearing loss. And when they get these flare-ups, they get these episodes, it can be hours, it can be days, they can happen for no reason whatsoever. It's thought to be caused by an abnormal fluid balance in the inner ear. So what they will typically do in severe cases, recurrent cases that are just not responding to other treatments, they can use surgery to decompress the endolymphatic sac. They can resect the nerve, or they can ablate the labyrinth. That in and of itself likely will result in loss of hearing. However, recurrent episodes of Meniere's can eventually result in loss of hearing as well. This is just a debilitating condition, and it's just really, really sad for the people that suffer from this. So when someone's having an acute attack of Meniere's, you want to try to minimize any type of stimulation. So bed rest, we want a dark, quiet environment. Try to sedate them a little bit. Antiemetics, because they are definitely going to be nauseated from that vertigo spinning sensation, and anti-vertigo meds. TV should be off. Any type of flickering like that can exacerbate the symptoms. We don't want sudden movements of head or position changes because, again, that can exacerbate the symptoms. As horrible as this is, it's not life-threatening per se. But it is very, very debilitating and very, very upsetting to the patient. Safety is always a concern because they are at major risk for falls and injury that way. Long-term management, some things that they have found that help are a low-sodium diet, because the whole idea of if they have high sodium, they're going to retain fluid, and that fluid is going to be retained up in the ear, and that can cause that imbalance. Caffeine and alcohol have also been associated with acute attacks, so trying to avoid those things. They will often treat them with diuretics to try to minimize the fluid that's retained in their body and hence in the inner ear. Vestibular rehabilitation, that really is basically learning how to work and how to cope with these attacks and the ongoing hearing loss and the effect that it's going to have on their hearing as well.